Hello, my name is Dr. James Finch, and I would like to welcome you to the third and final module in the course, A Guide to Rational Opioid Prescribing for Chronic Pain. The previous module dealt with the initial evaluation and treatment planning process when considering when and how to initiate treatment with opioid analgesics. We will now consider the issues and strategies related to monitoring and adapting treatment with opioid medications once it has been initiated. As you'll recall, these are the next steps in following the chronic disease clinical care algorithm we've been using as a basic structure throughout the course. The previous steps included, first, the initial patient evaluation to determine if there is an appropriate indication for opioid use, and to perform an adequate risk assessment to identify contraindications to their use, and the individual's relative level of risk associated with using opioid analgesics. Next, considering a trial of opioid therapy based on that evaluation with attention to adequate informed consent related to opioid risks and clear time-limited functional goals against which to measure treatment effectiveness. Now we will consider an approach to adequate monitoring, both in terms of treatment effectiveness, but also treatment safety, so that the treatment plan can be adapted to maximize effectiveness and interventions directed toward misuse or abuse of the medications, so those can be implemented if needed. In the past, monitoring often meant simply monitoring for pain relief, as indicated by reported pain scores such as the 0 to 10 numerical pain scale. Increasingly, however, the standard related to monitoring has evolved and broadened to include not just pain relief, but functional improvement in the absence of untoward side effects and/or problematic medication-related behaviors. For example, Dr. Pasick and Weinreb stressed the need to regularly assess and document what they labeled the 4 A's as a way to remember this more comprehensive approach to monitoring: analgesia, activity or function level, adverse effects, and aberrant behaviors. As pointed out earlier, it is worth emphasizing that it is best to make this increased level of monitoring clear from the start of treatment with opioids, and that for adequate assessment, it is at times necessary to rely not just on patient report, but ancillary sources of information as well. To improve time effectiveness and consistency, this process can be facilitated by designing the medical record, whether paper or electronic, to prompt and adequately document the attention to these 4 A's. Another time-effective strategy is to use validated patient self-report instruments that attend to not only pain score, but functional improvement as well. One such instrument, the Pain, Enjoyment, and General Activity, or PEG scale, is a straightforward 3-item patient questionnaire that was specifically designed and validated in a general medical setting to be as brief and time-efficient as possible, while still demonstrating validity in measuring response to treatment. Another similar instrument from the American Chronic Pain Association is the 10-item Quality of Life Scale. This instrument has the benefit of providing specific examples of varying levels of activity and functionality, staying in or out of bed, doing simple chores around the house, working actively outside the home, etc. And these examples may prompt or facilitate for both clinician and patient the process of identifying behavior-specific goals to monitor. Finally, it is important to regularly monitor not only apparent medication effectiveness, but also monitor for risk-related or aberrant medication-related behaviors. This is an area where recommendations and expectations for clinicians and patients has expanded significantly in the recent past, moving beyond the basic expectation of face-to-face assessment and patient self-report to include routine use of urine or other toxicology screening and regular recurrent use of your state's prescription monitoring program, such as the Controlled Substances Reporting System, or CSRS, in North Carolina. In more complicated or otherwise high-risk patients, it may be necessary to gather information on patient function or problems from collateral contacts, such as family members, or through contact with other co-treating clinicians. For particularly high-risk patients or those for whom concerns develop about misuse or diversion, it may even be necessary to use callbacks for random drug screening or pill counts. As you can see, level of monitoring varies depending upon initial perceived level of risk. Likewise, perceived level of risk may evolve as a result of ongoing monitoring. That is, perceived risk and level of monitoring may go down as the patient demonstrates responsible behaviors, or go up if worrisome behaviors present themselves. Setting up the systems for all this can feel like quite a challenge. But if you think of some of the other things you do, managing patients with complex diabetes, complex cardiovascular disease, clinicians can, with some planning, develop office systems that support opioid therapy and make it relatively straightforward to implement. But it does take some planning. First, develop medication-related policies, which are reflected in the patient-provider agreement, a clearly articulated plan of care that works with your particular office and patients. You may want to have a management flow sheet so that you can track opioid prescription renewals, a checklist for concerning behaviors that may occur, and where you can record pain and function scores. Any information that's going to help you efficiently assess how the patient is doing and how the patient has done over time. Having a list of referral and resources can also be very helpful. Do you know where the pain professionals are who can help you with care, or mental health professionals for patients who have co-occurring disorders and maybe using opioids as a means of coping? And where are the buprenorphine providers, methadone treatment centers, or addiction medicine specialists who may be helpful to partner with for patients who have co-occurring disorders? In the face of these increased monitoring expectations, it's important to realize that all of this is not the direct responsibility of the prescriber. You can delegate many of the routine things that need to be done to other professionals in your office. The medical assistant or even the receptionist can help assist in these tasks. They can check the prescribing monitoring system reports, perform or schedule random urine drug screening, or arrange referrals. They can track that patients are keeping physical therapy appointments or mental health pain specialists or other recommended consultations. And they can make sure that all this information is posted in an organized manner so that you can glance at the record when you have an appointment with the patient and see what's going on, particularly if they flag concerns or things that are not as might be expected. Roles can be assumed by nursing staff as well. For example, reviewing the plan of care with the patient, discussing medication and other treatment risks and benefits, and providing education on opioid effects and side effects. Also, at the time of visits, assessing the patient's pain, level of function, and other clinical information can be done by nursing staff. They can do the pill counts if needed, and they can manage and monitor prescription refills and serve as a liaison with the pharmacist, which brings up that the pharmacist also can be a great ally. It can be useful to suggest or expect the patient to use only one pharmacy. While filling prescriptions, they'll be seeing the patient in a different time and setting. They can provide information or education to the patient regarding medications, and they can also let us know if there are concerns or issues that arise during their interactions with the patient at the pharmacy. Of course, routine adequate monitoring is not an end in itself. It is to enable the clinician to adapt the treatment plan as needed to maximize effectiveness and minimize potential problems with misuse or abuse of any control medications. So one aspect is adapting the treatment plan in the setting of reports of inadequate pain relief. This is addressed not only by adjusting the opioid regimen, but through consideration of the use of non-opioid adjunctive analgesics, and of course the range of non-medication treatment modalities available for chronic pain management. This will at times involve responding to recurrent requests for increases in opioid doses, including requests for opioid doses that have escalated into higher risk levels. This makes it important that the clinician is aware of his or her comfort zone when prescribing opioids. When in doubt, ask for help. Through consultation or referral, that help can be available. In that light, consider the benefits of establishing protocols for responding to escalating dose levels. For example, suggesting or requiring consultation when total opioid dose goes above a certain level, such as 50 to 100 morphine milligram equivalents. There's been increasing attention in the past few years to the risk associated with prescribing higher doses of opioids. In this report from the CDC, high dose was defined as doses 100 morphine equivalents and looked at the association between higher doses and overdose risk. This study shows that while only 20% of patients are prescribed opioids at this level, 80% of overdose deaths occur in this cohort. In addition, only half of those who overdosed were seeing multiple prescribers, the group that would include so-called doctor shoppers. Half were seeing only one medical provider. This study highlighted the risks associated with doses above 100 equivalents, but other studies have highlighted a significant escalation of risk at lower total doses, such as 50 equivalents. And these reports relate only to increases in overdose risk. Other studies and authors have highlighted other medical risks associated with higher opioid doses, risks such as cardiac dysrhythmia, sleep apnea, and hormonal dysregulation. These statistics underlie a number of protocols and recommendations, such as the CDC recommendation to limit dosing to below these levels and or to require a higher level of assessment or monitoring as doses go above these levels. When confronted with a patient who continues to report inadequate pain relief and asks for escalating doses, it's useful to get curious about why medications are not working as intended, to reinforce emphasis on multimodal pain management, as opioids can be useful but are rarely sufficient, and track and reinforce the importance of active self-management. You can also return to the concept of therapeutic trial. If the medications aren't helping, why continue to escalate? Beware of chemical coping, the use of opioids to provide relief from emotional pain or distress, or to provide energy or activation in the setting of depression, fatigue, or overwork. The following clinical role play provides an example of how it might sound responding to a patient requesting an increase in opioid dose. Alicia, you came in for help with treating your knee pain, and we've done an evaluation, and I think we have some ideas of things that are contributing to your knee pain. So I think it's time for us to talk about some treatment options. Did you have an idea of what you thought you needed in terms of your knee pain?
Yeah, so my last doctor didn't give me any oxycodone, and I never got out of pain the entire time I saw him. Mm-hmm. So I really think that I need to get back on the oxy that I was on before.
Mm-hmm. So you did get relief from the oxycodone?
Yes, I did.
Okay. Well, we'll keep that in mind, because I think it may be that oxycodone will be one of the things we end up using, or something similar to that, an opiate analgesic. But in looking at your record and talking with you about your record, there's some things for your particular kind of pain that really haven't been tried. So I think there's some other treatments that we want to try to make sure that we're doing the right treatment for your particular pain. And I think we'll start out with those, and we'll kind of hold the oxycodone in reserve for the time being. What do you think?
I really think I'm going to need the oxy somewhere in there.
Mm-hmm. And again, you might. I'm not ruling that out at all.
Okay.
But I have to take into consideration that opiates have limited evidence in terms of their use for the long term. We're not really clear that they work well for the kind of chronic pain that you've got. They have some risks associated with them, dependence, overdose, that sort of thing. They tend to work best when used with other treatment modalities anyway. So I think we're going to want to use a multimodal approach anyway. Okay? So that's what I think makes the most sense. Can you live with that or go along with that?
Yeah, I guess I can.
Okay. All right. Well, let's talk about some of the specifics and we'll get started.
Okay.
Now let's return to the other stated purpose of monitoring, identifying and addressing problematic or aberrant medication use, an aspect of this process that many clinicians, regardless of discipline, find difficult or awkward. Many clinicians worry about inadvertently facilitating inappropriate use of medication, being manipulated or scammed, or even running into regulatory or legal problems while prescribing opioids. To address these legitimate concerns, it is important that clinicians have a working understanding of the kinds of problems individuals get into with opioids and have a means to distinguish between overusing or otherwise misusing opioids versus abusing or being addicted to them, behaviors which may look similar on the surface until explored. And then be able to target the intervention or change treatment based on the kind of problem identified. However, some clinicians, not to mention family members and the public at large, lump many of these behaviors under the phrase drug-seeking behavior, a phrase that unfortunately is nonspecific and at times pejorative. Although potentially useful as a red or caution flag to gain the clinician or staff's attention, the observed or reported behaviors often need further assessment to determine if they represent one or more of the conditions we discussed previously, conditions that warrant widely different therapeutic or even legal interventions. Let's look at some of the common categories of medication misuse, starting at the less pathologic end of the continuum. Sometimes misuse of opioid medication may be unintentional, secondary to confusion, complicated medication regimens, or cognitive or sensory impairment. In this case, the intervention may be to problem solve with the patient or the family or caregivers to simplify the regimen, avoid look-alike medications, or engage the family or other caregivers to help with managing the medications. A variation on this is a person's misuse of controlled medications in misguided attempts to self-manage inadequately treated pain. This was sometimes referred to as pseudo-addiction because the behaviors, running out of medication early, asking for additional refills, using other people's medications, going to multiple doctors, making frequent visits to the emergency department, looked to clinicians like addictive behaviors and were often labeled as such: overusers, doctor shoppers, etc. Response to these behaviors first requires curiosity and adequate assessment, and then reassessment of the pain management plan, including controlled and adjunctive medication as well as other therapeutic alternatives. This may be the time to recognize the need for referral for consultation for further input or expertise on more effective pain management strategies. Again, monitoring and assessment are an ongoing process. If the problematic behavior does not resolve, it may indicate that the behavior indicates a more serious problem with misusing or abusing the medication, and that it is real addiction, not pseudo-addiction. In this case, it may be time for a psychiatric or substance abuse consultation and more intensive monitoring. Before moving on, it's worth pointing out once again that inadequate pain relief does not necessarily mean an increase in the opioid dose, or that that's indicated. Beware the old adage, when all you have is a hammer, everything looks like a nail. Alternate or adjunctive non-opioid therapies most likely are needed in this setting. Another common domain of opioid misuse is for so-called chemical coping, that is, the use of opioid medication to help deal with poorly managed emotional comorbidities, particularly mood disorders like depression, anxiety, and agitation. Intervening with chemical coping may be relatively straightforward or quite complex, since chemical coping can represent a complex interplay between physical, emotional, and situational factors. These factors can often reinforce over-reliance on medication like opioids, medication that seems to provide relief for the emotional and physical pain, even as it is making many of the underlying contributing factors worse. For many patients, clarification of the mitigating problem, education and exploration of alternatives, more appropriate use of focused therapies, and restatement of the treatment agreement may be all that's necessary. For others, a complex interplay of emotional, situational, and financial, and possibly substance use-related factors may make intervention challenging and at times frustrating. Referral for psychological and/or substance abuse evaluations may help clarify the issues needing attention and can identify behavioral interventions that may be helpful. Behavioral interventions targeted toward not only insight but guided behavior change, including mood management or stress tolerance skills or attention to trauma processing that may be particularly helpful for some. It's worthwhile identifying clinicians conversant in these modalities who are available for consultation or referral. Unfortunately, relative lack of access to these modalities, as well as their delayed payoff compared to the relative ease and seeming effectiveness of the misused medications, may make it difficult to motivate the individual toward change. This is particularly true when personality disorders impede the individual's insight and make interactions with the clinician at times problematic. When appropriate, make referral and participation in these modalities part of the therapeutic contract for continuing the use of opioids, preferably early in the therapeutic conversation rather than only when problems develop. If the clinician sees a pattern of medication use that is suspicious of a substance use disorder, moderate or severe, he or she should confront the issue in a direct, non-threatening way. The issues should be presented as concerns in a behaviorally specific, non-labeling way. It's generally best to start with curiosity about the patient's behavior, how he or she used the medication or medications, what they were trying to accomplish, what was good and not so good about using the medication in that way. This is also a good time to talk about the use of alcohol or non-prescribed or illicit drugs in the setting of pain management with opioids. At a minimum, safety makes it necessary in this setting to ask about use of alcohol or other drugs, particularly given the risk of combining any sedative drugs with opioids. As a result, questioning patients and using urine toxicology over other drug screening are now considered a routine part of prescribing practice when using any controlled, that is, abusable medication. In addition, it's generally accepted that misuse of alcohol or other drugs can be associated with the misuse of prescription medication, so any use requires further evaluation either by the medical clinician or by referral. Accessing the perspective of family members or close social supports can sometimes help gain a better perspective on this use. Misuse of other drugs is generally a contraindication to prescribing opioids. As stated earlier, sorting out the differences between misuse of medication from a persistent pattern of problematic use consistent with loss of control and addiction can sometimes be a difficult task, since on the surface, the behaviors may appear similar. Further assessment may indicate a difficult interplay of physical, emotional, and/or situational factors, sometimes referred to as complex opioid dependence rather than addiction per se. At times, following carefully over time will more clearly demonstrate the underlying pattern and dynamic. Sometimes referral for evaluation by a mental health or substance abuse consultant may help to sort things out. However, at times, even when the underlying dynamic is unclear, it's necessary to err on the side of safety and limit or discontinue opioid use. Again, when confronted with potentially problematic behaviors outside the established treatment agreement, the first necessary response is to get curious, and the following clinical role play gives an example of how this might progress.
Afternoon. So how are you doing?
It's okay.
I'm not sure I feel really convinced about that so far. So how's your month been?
It's going all right.
Okay.
It's hard, but
Okay.
it's okay. The pain's been worse.
Okay.
I think that I might need some more pills. I don't think that 5 is enough.
Okay. So how long did it take for you to come to that conclusion?
It's maybe a couple weeks.
Okay. And so what do you notice start to happen?
I think I've been really stressed lately. I have a new boyfriend, and, trying to introduce him to the kid has been hard, and I'm just finding that I get really stressed and hot and just feel really on edge. And
Okay. When is this feeling on edge and feeling hot occur usually in the day? Any particular time?
usually right before lunch. It just seems like once I'm up and having to deal with life for a little while, it kicks in. And I've got a cold too. My nose has been so runny lately, and it just...
Okay.
I've been taking some Benadryl. That helps.
Okay. How you sleeping?
I wake up maybe twice a night.
Okay. What's your pain been averaging? Pain score, where'd you put it?
Just over a 10.
Okay. So tell me exactly how you're taking your meds.
I mean, the same way that you prescribed them.
Okay. And some days you're less than 4, some days less than 5, sometimes more than 5? Or are you taking them pretty ritually every time?
I don't think there's any days that are less than 5.
And some days more than 5?
Maybe a couple.
If problematic high-risk use of medications or other drug use is reasonably confirmed, it's important to weigh the risks of continuing therapy with a controlled medication and to express these concerns with the patient in terms of the patient's well-being, not in terms of risk to the clinician, although that risk is real as well. For example, it might sound like, I know that you have a problem with pain, but I believe you also have a problem with how you're using your medication. These are the things I've noticed that worry me. Then ask the patient if they also see these as concerns. This is the beginning of engaging them in a motivational process of changing their at-risk behaviors. In some cases where immediate safety is a concern, such as a combination of opioids and benzodiazepines or alcohol abuse, referral for inpatient detox and treatment may be appropriate or necessary. In certain cases where continued pain management is necessary and safety issues are considered manageable, it may be appropriate to continue therapy in a more closely monitored manner with much tighter medication management. Again, this will vary from clinician to clinician and clinical situation to clinical situation. Stay within your own personal comfort zone. At a minimum, consider referral for a substance abuse assessment to help guide intervention and treatment. In those cases where the clinician has done his or her best to work with the patient within the limits of safety and the patient has been unwilling or unable to comply, it is necessary to discontinue prescribing all controlled medications. In some cases, it may be possible to safely manage an outpatient structured withdrawal from the medication, but if immediate cessation of prescribing is indicated due to safety concerns, it is necessary to assess for withdrawal risk, and it is necessary to refer or otherwise offer options for withdrawal management. For those with moderate to severe opioid use disorder, including physical dependence, an additional option is substitution or agonist therapy, either by referral to an opioid treatment program, often called methadone program, or to maintain the patient within the same practice by switching to buprenorphine, prescribed by a clinician with the practice license to prescribe this medication for addiction. When the patient demonstrates a pattern of severe opioid use disorder, particularly when it is chronic and persistent, there are 3 therapeutic options which can be considered and discussed with the patient and family. The first is detoxification from all opiates and subsequent engagement with abstinence-based therapy, often intensive outpatient therapy, with ongoing involvement with mutual support groups such as Narcotics Anonymous or Smart Recovery. The second option is referral to an opioid treatment program that can provide methadone as a substitution therapy. This must be through referral to a licensed opioid treatment facility or clinic. It is illegal for an individual practitioner to provide methadone for the treatment of addiction through their own office or practice. Finally, buprenorphine substitution therapy may be provided in an office-based setting by a medical clinician, MD, PA, or nurse practitioner who has obtained the necessary DEA waiver to do so, provided by someone in your own practice or referral to another licensed practitioner. When the decision is made to discontinue opioids that have been used chronically, the patient's risk of withdrawal and its complications must be weighed against the urgency of safety issues involved. When relative risk is low, it's appropriate to use a routine taper to discontinue the opioid with prescriptions and frequency of visits dictated by the patient's stability and ability to comply. Serious concerns about safety related to the individual's pattern of misuse, their ability to successfully comply, may result in the need to more structured, more rapid tapers, or even discontinuing the opioid acutely and treating the patient with outpatient withdrawal protocols. When concerns for safety are highest and evidence of addictive behavior is clearest, it is appropriate to refer directly for inpatient detox or substitute opiate agonist therapy. In this setting, it would not be reasonable or necessary to provide any further opioid prescriptions to the patient, as the patient has already demonstrated that they can't handle them responsibly or safely. This is not abandonment. The clinician is not denying or terminating care, only terminating the prescribing of opioids. The following clinical role play demonstrates how the discussion about discontinuing opioids might play out.
I mean, I did run out a little bit early last week, but
Okay.
My boyfriend has a script. He gets one from the VA, so I can, borrow if I run out.
So you ran out like how early? Like 5-6 days early? 7 days early? A week?
About a week ago.
Okay.
Yeah.
And what does he have?
He's got Darvocet.
He's got Darvocet?
Yeah.
Okay. And how many of those you been taking?
Just as needed.
Which means what?
Maybe just a couple at night, mostly.
Okay. Do you feel like you had any withdrawal from the 5 that I was giving you?
I mean, I don't think I'm addicted or anything.
Okay. Let me check something here, if you don't mind. So, by what I see here, your urine drug screen last time, did you expect to have anything in there other than the pain meds? Because it was positive for marijuana again.
Yeah, my boyfriend smokes.
So are you saying you don't smoke, or?
No, but I mean, I'm around him when he smokes, so probably just, we're sitting around and he's smoking. Probably just picked it up.
So the level of this doesn't look like it's passive smoke inhalation. And also, it's pretty rare to get a level of any at all if you actually haven't inhaled and actually used some. So I'm sorry, but I'm kind of worried about what's going on here. And so with you increasing your dose, being out, getting meds from your boyfriend, which is way against the contract, like we've talked about before, and I've been really clear about this, along with marijuana again, I'm not going to be able to write anymore. We're going to have to take a break from this. Because also I'm not convinced that the meds are doing a whole lot. Because every time that we start with a medication, you get some pain relief, and then it stops being effective, and you increase the dose, we do it again, you increase the dose, we do it again, and here we are at the third round, and we're not getting anywhere.
So what do you expect me to do?
Well, the reality is, if the meds aren't working, that's not the way to go either. And so there's a bunch of things you can do. Back to physical therapy, we can try non-opiate medication. I'd be willing to give you some tramadol, Ultram, make sure you're doing NSAIDs, make sure you're doing your physical therapy, etc. But these meds aren't working. And if they were working, you would not be having this kind of response.
So
And
you're
also,
saying that I waited like 4 months to get into your office after that wait list, and then I have to pay $50 copay on my insurance, and you can't even prescribe to me, and I'm still in pain?
the reality is, I did prescribe for you. And I did try 3 or 4 different rounds. And you've broken the contract 2 different ways. And also I asked for collateral information, have your mom come in, somebody come in. You totally blew that off. Right?
Somebody has to take care of the kid.
Oh, I hear that, but for me to give you meds, of which many people die every year, and some people this works for, some people it doesn't, I'm unwilling to continue. I think it'd be unwise treatment for you, and it feels like it's unsafe, especially if you're the boyfriend's in the house giving you meds in addition. Unsafe situation. My job is your safety, not necessarily just a comfort level for pain. And so I'm going to have to bow out in terms of giving you those kind of meds. I'm willing to give you other things, like I said, tramadol, Cymbalta, which sometimes can work as a pain med, Neurontin, other things I can give you, but I'm not going to give you any more controlled substances.
So if you're not going to take care of my pain, can you refer me to someone who will?
Be happy to. There's a number of clinics around. I'll give you like 2 or 3 different names, and you can see if they're willing to do anything else. And feel free. And if you're out there and you feel like that's not working, and you want to try to come back here without the expectation of having controlled substances, I'm happy to see you back. But from here, at this point in time, no controlled substances from our clinic.
Okay.
Okay? All right. Best of luck.
Before we move on, I want to reinforce the potential utility of so-called substitution or agonist therapy for the difficult clinical situation of providing care for someone with severe opioid use disorder, commonly called opioid addiction, who may also have genuine chronic pain. Substitution therapy in this case means substituting an alternate opioid agonist for the opioid of concern, whether it is illegal heroin or prescribed oxycodone. Agonists activate a particular receptor, in this case the mu-opioid receptor, and mimic the normal response that's produced by that receptor's natural neurotransmitter. Substitution or agonist therapy takes advantage of this cross-reactivity by substituting a less euphorogenic, less abusable, generally longer-acting medication for the short-acting opioid that the individual has been abusing. As stated, there are now 2 alternatives available for this form of therapy: methadone, a full agonist, and buprenorphine, a partial agonist. It's important to emphasize that in addition to blunting craving for other opioids, both of these substitute medications are excellent analgesics, meaning they offer the potential for pain relief while minimizing the potential for abuse. Untreated pain is a strong trigger for a return to problematic opioid use. These medications offer a safer alternative. As a note, there's also an opioid antagonist available called naltrexone, but it's only an alternative when the individual is no longer physically dependent on opioids, such as after taper or detox, and when opioids are no longer needed or reasonable for treating pain. Unfortunately, opioid agonist therapies, in the way of methadone programs or prescribers waived to prescribe buprenorphine, are not always readily available in many communities. So it's worthwhile to explore in advance what's available and where. This is also why it is worthwhile for you to obtain the DEA waiver after completing this training and consider being available to prescribe buprenorphine when needed. This will provide a valuable resource to your patients and your colleagues, and will often turn a particularly problematic, difficult to manage patient into one who can be successfully treated without requiring outside referral. So we've come to the end of this module related to monitoring and intervening when prescribing opioids. In conclusion, intervention for aberrant medication behaviors should be tailored to the specific level of problem. When abuse is identified, a higher level of treatment engagement and monitoring is necessary for the medications and may lead to them being discontinued. Methadone or buprenorphine are useful alternatives for opioid addiction, particularly in the setting of chronic pain or psychiatric instability, and completing the waiver process would provide you with another valuable tool when dealing with some difficult clinical situations. Thank you.